shorter needles, and that's an example of a 30 mil needle. Also needle the ligaments, chronic ligamentous injuries. We can needle the tendons. We can needle around the tendons for a tendon inflammation, or an acute tendonitis, or a peritendinitis, or for a tenosynovitis, which is of inflammatory origin, or with your chronic tendinopathies, we can needle into the tendon. Let me just say now that we do not teach needling the ligaments and the tendons on our level 1 course. Our level 1 course is our introductory type of course, where we teach you how to needle the majority of the main muscles that you see in everyday practice. For example, trapezius, biceps, rhomboids, hamstrings, calves, quads, quadratus lumborum, gluteus medius, and minimus. The muscles you see on a very regular basis. On the level 2 course, we teach you how to needle the tricky muscles, the difficult muscles like pectoralis minor, masseter, and the pterygoid inside the face. We also teach you how to needle hands and the feet, and the abdominal muscles. We teach you how to needle the deep external rotators of the hip, like the obturator internus and quadratus femoris, which lie very, very close to the sciatic nerve. And we needle them safely and effectively because we focus on anatomy, we figure out with bony prominences and with our surface anatomy where the likelihood of, for example, the sciatic nerve is going to be. And we make sure that we needle away from the sciatic nerve. Okay. So where does dry needling come from? Why the term dry needling? Dry needling is becoming more and more popular. It's been around for a long time. I'll give you an example of how long. You all know that I'm about mid-50s, right? And I qualified as a physiotherapist in 1988. And in 1991, I did my first dry needling course. So that is almost 30 years, 28, 29 years. So I've been needling for a long time. Dry needling came about a lot further back than then, when Bell and Simmons were treating their patients with muscle pain by injection. They were injecting lidocaine, marcaine into the muscle for the pain. The pain was going away. And they were using a hypodermic needle. So to cut a long story short, they changed to sterile injections to the muscle, and the pain was still getting better for the patient. So then they thought, well, let's just put the hypodermic needle in and not inject any solution. And the patient's pain was still being relieved. So they then obviously thought, well, the hypodermic needle is a large needle. It causes a little bit more damage. Let's see if we can do this a little bit better, and let's use an acupuncture needle. They were treating muscle pain with acupuncture needles and sticking the needle in 30, 40, 50, 60, 75 mils to treat the patient's myofascial or musculoskeletal pain. And that is where dry needling and the term dry needling came from, as opposed to wet needling. The wet needling would be referred as an intramuscular injection to the muscle, whereas dry needling is now using an acupuncture needle to treat myofascial pain. Now, what we focus on is a trigger point. And a trigger point is an area in the muscle, a focal area in the muscle or in the fascia, where you have a hyper-irritable band or a knot developing in that muscle. It develops as a result of either microtrauma or macrotrauma. Microtrauma being postural changes, muscles being put on a stretch, a spasm. Macrotrauma being a stretch of a muscle through sprinting, a bruise, tearing the muscle, some form of trauma to the muscle. And trigger points develop either over a long period of time, or if it's macro trauma, they'll develop subsequent to the trauma to the muscle. And trigger points are generally painful to compress with your palpation. If they're severe, they can cause local and referred pain, muscular dysfunction, stiffness, weakness, and autonomic changes in the muscle. Trigger points can cause referred pain, and the worse the trigger point, more painful it's going to be for the patient. So in simple terms, a trigger point is a stiff, localized spot of exquisite pain and tenderness in a taut band within a skeletal muscle that reproduces the patient's pain. Now, we need to briefly understand the physiology of the muscle. Now, I'm not a physiologist, and I was at university a long, long time ago, but I can remember muscles contract, and they contract because of proteins within the cells. And your proteins that are responsible for contraction are actin and myosin. And actin and myosin bind together when there is the presence of calcium within the cell or the cells of the muscle, because calcium then changes the tropomyosin protein, and tropomyosin, which normally covers the actin and the myosin binding site, it changes its shape and it exposes the binding site, and that allows actin and myosin to bind together. Now, I'm not going to go into the full-on these slides here. You all get a copy of the introductory slides afterwards. No problem. I'm not going to go into too much detail. Suffice to say that calcium is released when an action potential comes down the nerve. It's released in the cellular area of the muscle, and calcium is thus responsible for the contraction and the contractility of actin and myosin to cause the muscle to contract. It's known as the sliding filament theory. Now, what is supposed to happen in normal muscles, like what is happening here
Can
to
you share
you
with
guys
us the evidence
as I
for
use.
dry needle for each point?
Sorry, can you ask that again?
What about the evidence base for dry needle? If you have any reference for each point when
Yes,
you
we do.
talk to it.
We do have references. I'm not going to go through the references today because we don't have enough time, but I can send you a full reference list, no problem.
Okay, thank
Yeah,
you.
pleasure. Okay, so we're just talking about the muscle contraction because I want you to understand how needling works. So actin and myosin are responsible, and they contract because of the presence of calcium. Now, can you imagine that calcium has to be removed out of the cell, because then the actin and myosin have to detach, and that is how the sliding filament theory of muscle contraction works. So in a normal muscle, you have calcium coming into the cell, actin and myosin bind, calcium is taken out of the cell, and actin and myosin detach. And that's happening all the time when the muscle is contracting. If you get a buildup of calcium in the area and the calcium is not removed from the hundreds or thousands of cells within that pathology of the muscle, then you develop a spasm and a hypercontractility within that muscle. And I'm just going to go forward to this slide over here. So you can see here that you have a vicious circle developing, where initially your cross bridges form, your actin and myosin bind together, and then your calcium is supposed to be removed out of the cell to allow those cross bridges to detach, and the calcium remains in the cell, and this now becomes an area of spasm within the muscle. And we need to break that spasm. And you can imagine thousands or millions of muscle cells are in spasm, and they form a band or a knot, and we come along with our needle and we stick the acupuncture needle into the band within the muscle, and we deactivate the trigger point. The trigger point is active. We deactivate the trigger point. We try and get as many twitches, which is a sign of the deactivation of the trigger point. We're trying to get as many twitches as possible, get that muscle to relax. So just talking about the local twitch response. Some of you who may have some experience with dry needling will have seen videos or will have seen patients, their muscles twitching when the needle goes into the trigger point. And the twitch is a characteristic of the trigger point releasing. And that is really what we are looking for, the local twitch response. It's a spinal cord reflex characterized by an involuntary contraction of the contracted taut band. It's elicited by a snapping palpation with the penetration of the needle into the muscle. Okay, now, if I could just go back, let's just deal with the classification of trigger points, just very, very briefly. So the trigger points we're trying to deactivate are mainly the active trigger points, because active trigger points cause pain in the muscle. These are the trigger points that patients are coming to see you for. A latent trigger point is not painful. A latent trigger point can still exist in the muscle, and it can become an active trigger point if it is stressed. And an active trigger point, when we turn it off, we reduce the pain, will become a latent trigger point. Active trigger points cause spontaneous pain. They will cause a twitch in the muscle, and they can also cause muscle weakness and decreased flexibility. So too can the latent trigger points. Okay, they can also have some degree of weakness. You will
May I ask
also
a question,
elicit.
please?
Sorry, what's the question? So the latent trigger point will also, you will also get a twitch response. And that's what we notice on our courses, is that when we're practicing on each other, a lot of the people don't have pain, but we get lots of twitches in the muscles which are pain-free. And that is the latent trigger points that are twitching as a result of the needle going into a latent trigger point. You can also classify the trigger points in accordance with primary, which developed first or second, and secondary trigger points, satellite trigger
Please,
points in the
can I
pain
ask a
referral
question?
areas. Yes, go ahead. Yeah, go ahead.
What is the difference between the latent trigger point and just the tender point?
The difference between the latent trigger point and the tender point.
Tender point only, not lessons.
Most of the tender points in the muscle, their trigger points will be active trigger points, especially if that's where the pain is coming from for the patient. So the characteristic difference is that your patient will experience pain. They'll come to you with a headache. They'll say, "Doctor, I have pain in my head. It's here in the back of my head, and I feel my neck is stiff and sore as well." And then you palpate in the neck, and you palpate and you reproduce the patient's pain. So if the trigger point in the neck is causing the headache, that's an active trigger point. However, if your patient comes with shoulder pain and you're palpating and you're pressing in their trapezius muscle and it's painful, it's not their pain, it's not causing their shoulder pain, and that trigger point in the trapezius is a latent trigger point because it's not causing their actual pain. The actual pain is coming from somewhere else. Okay, then you also get satellite trigger points, which develop in pain referral areas. So, for example, if your patient has sciatica and they have pain in the calf or pain in the hamstring, the trigger points can develop in those muscles where the referred pain is felt.
So while we have a tender point, we have not to deal with it to don't open a plus pain to patient or make he dissatisfied with another pain. Is as useful, or we have to deal with tender point only, even patient doesn't feel pain from it.
Now you have to deal with the diagnosis of where the pain is coming from. So if I can give you a clinical scenario, if a patient comes with back pain and they've been referred by a specialist and the specialist says the patient has sciatica in the back, please, the pain is coming from the disc, all right? If you assess that patient and you look at the patient and they see they have full range of movement, they can do flexion, they can do extension, they don't have a positive slump test, in your examination, it doesn't look like they have a structural problem in the spine. And the sciatic pain referral can be coming from the muscles of the back, for example, the quadratus lumborum, or, for example, the gluteus medius or minimus. So you need to identify specifically which muscle the pain is coming from and exactly where in that muscle the pain is. Because muscles can refer pain just like nerves can refer pain. Okay.
Would you please, Craig, we can collect some question after session one, after part one, so you can go on. Maybe a lot of point could be explored after this.
After 1 minute.
Teaching, yeah.
Sorry, I just needed to close the window. Sure. Don't mind if people want to ask questions if I'm going a bit too quickly or if they're confused about something. But yeah, sure. If we could collect a few questions at the end of, let's say at 6 o'clock, and then we'll answer those questions.
Yeah,
okay, so
thank you.
Trigger points can also be in the middle of the muscle. This is central trigger points, and also at the attachment in the muscular tendinous junction. So a trigger point can basically develop anywhere in the muscles, but let's also understand that trigger points often develop in the same places of some muscles. So if you examine the trapezius muscle, you will often find in the distal portion of the trapezius muscle over here, near towards the acromioclavicular joint. That is where the trigger points often develop in your trapezius muscle. How do you diagnose a trigger point? Trigger point is easily diagnosed because, number one, you're going to feel a tight band within the muscle. Number two, you're going to elicit a twitch response when you stick a needle into that band. Number three, you're going to get extreme tenderness in the taut band, and you're going to reproduce the patient's pain. Is someone drawing on their... Everyone see that red squiggle?
Yes.
It's not me. I'm sorry. I'm not. I'm not drawing on the presentation. Apologies for that. I don't know where it's coming from. Okay, so this is the picture, a diagram of a muscle. Okay, and there you can see the band inside the muscle. And if you just expand that band, you can see that some of these cells here have got trigger points, contracted knots, and some haven't. So in the band, what sometimes happens is you palpate the band and you put your needle into the band. You can feel the needle going into the band. Sometimes you get a twitch and sometimes you don't. The reason for that might be that you're going into the contracted knot, the contracted muscle cell in that band, and sometimes you're not hitting the contracted muscle cell. Okay, so that's just an expanded view of the band where some of the fibers are contracted and some aren't. Also, sometimes you won't get a twitch in the muscle because sometimes you're not actually dealing with a trigger point. Sometimes you're dealing with just pure myofascial adhesions, in other words, tightness between the fascial layers, or you're dealing with scar tissue in the muscle. Okay, so we've spoken about how to diagnose the trigger point, and the common clinical findings are going to be mainly the pain. You're going to reproduce the patient's muscle pain. The pain can be local. If the trigger point is severe, the pain will also be referred. We spoke about the cause being micro and macro trauma, and you're going to elicit a twitch response, and there's going to be abnormal tissue tension or tightness, which can be associated with stiffness, shortened range of motion, positive stretch sign, and also some autonomic disturbances within the muscle as well. The way we palpate trigger points is very, very easy. We either use the pads of our fingers and we roll them over the band and we can feel when we get to the painful area, or we pincer grip our fingers like that. For example, the latissimus dorsi muscle or the trapezius muscle, and then we can feel the band rolling between our fingers, thumb and the middle finger or the index finger. But there are a couple of proposed mechanisms that are in the literature. For example, trigger points may arise from abnormal muscle spindles, or trigger points may arise from neuropathic pain sensation. So with the referred pain being felt in the area of the muscle, the trigger points develop in that neuropathic area within the muscle. There's a scar tissue hypothesis that in the presence of trigger points, scar tissue develops. And the final hypothesis is the dysfunctional end plate, or what we call the energy crisis, which is, as I've described, where there's a micro and macro trauma to the muscles, which releases excess calcium within the muscles. Calcium is not removed, so the muscles remain in a hypercontracted position. We know that if the damage was repairable, then the calcium would be removed. But because the calcium remains in the area, we get a sustained muscular contraction, which results in spasm or tension, bands develop, knots develop in the muscle, and that is what we would call a trigger point. So where is the pain coming from? Pain's coming from the increased local metabolic demand, because if you can imagine within a band, the muscle and the fibers are hypercontracted, you're going to have vasoconstriction, which leads to decreased blood flow, which leads to decreased oxygen, which is called hypoxia. Your tissue energy crisis will then also release your sensitizing nociceptors and causing your pain in the muscle, such as your bradykinin, the substance P, your prostaglandin, and so forth. Okay, so back to the vicious circle. Sustained sarcomeric contracture leading to a band developing, which results in lack of blood flow, lack of oxygen, your energy crisis starts to develop, your calcium has not been removed, and your tissues remain in a hypercontracted state. And this is diagrammatically how a trigger point develops. And again, we come along with our needle, and diagrammatically we break that sustained sarcomeric contracture. We release the calcium, we improve the blood flow, we deactivate the tension within that band, activating the trigger points, getting twitches, as many twitches as we can, and within hours, within 2 to 3 to 6 to 12 hours, depending on the severity of the trigger point, your patient will immediately start to feel better. Now, the patient gets better and the symptoms get less because two things happen when you stick a needle to the muscle. Number one, you get a local reaction. You get local improved superficial vasodilation, improved local blood flow. And number two, you get a central reaction. You get a release in your brain of your endorphins, serotonin, the happy drug or the love drug within your brain. And that also has an immediate effect on the pain that you feel. So the effect of the acupuncture needle is locally the muscle and also centrally within the brain. Okay, are there any questions at this stage about trigger point, about why we're needling a trigger point, about how the needle works, before we get into the actual clinical aspect of needling and the contraindications and the complications? Any questions? Fire away. No questions. Okay, cool. Let's carry on. All right.
Craig,
yes, Naima.
Yeah. Regarding dry needling, I have done dry needling courses, so it's a revision. Sometimes the patient comes repeatedly. Some patients they come for dry needling over and over. How would you? I mean, what would be your approach? You know, they feel that dry needling it relieves their pain, and they come over and over for dry needling. Would you dry needle the same muscle again and again, even if like after 2 months or after 6 months or whatsoever?
Well, Naima, you get those types of patients that they become kind of addicted to the treatment.
Mm-hmm.
Yeah, so I'm happy for me to treat them, even if they don't really need it. If that's what their need is, if that's what their coping mechanism is, then on a regular basis, and regular for me would be on a weekly or every 2-week basis, if they want to come in for a little bit of maintenance, a little bit of needling maintenance, because that really helps them psychologically as well as physically in the muscles, I'm happy to do that, no problem. Most of the time, I will discharge my patients and I will tell them, right, you're fixed, you're finished, you don't have to see me again. If you want to come back in 2 weeks or a month's time for a checkup, by all means, no problem. But as far as I'm concerned, you are fixed.
Okay. Does it affect the muscle or muscle fiber if you're needling the same? I mean, sometimes it just occurs to me. Would be any damage to the muscle or as such? I mean, just
no. Needling is not going to cause long-term damage, even if you do needling on a regular basis. What happens with needling is there's short-term micro damage. You can imagine you're putting your needle into the muscle, right? And you're needling. And when we needle, we fish and we probe and we stick that needle in and out like that. That causes two things. Number one, if it's a trigger point, you're getting your twitches. It is deactivating the trigger point and it's causing a change and a reduction in the tissue tension at a microcellular level, and it's improving the blood flow. And that's ultimately what we want to do. Mm-hmm. However, if you needle very aggressively and you needle for a long time, then you also cause bleeding within the muscle, micro trauma and micro bruising in the muscle. Now, that's not necessarily a bad thing, because in chronic conditions and in scar tissue, that's really what you want to do. You want to break up scarring. You want to promote blood flow. You want to improve the blood flow to the area of that grotty, knitted, scarry muscle, so that that muscle is going to heal a little bit, a lot, significantly, enough for the patient's symptoms to be diminished so that they can do what they do.
Yeah.
So whilst needling does cause trauma, all right, it's quite insignificant trauma unless you put the needle into an artery. And the common area where that can happen is in the calf, because you've got the posterior tibial artery. It runs the deep compartment. If you needle with this 75 mm needle all the way into the calf muscle, there's a very good, especially in the midline, there's a very good chance that you're going to hit the posterior tibial artery. And if you needle and you're needling, you're probing on that same line all the time, you will damage that artery and you will cause a significant contusion or a hematoma within the deep compartment. Then your patient will be stiff and sore for days because they will have bleeding, diffuse bleeding into the compartment, into the muscle. That will cause stiffness and pain in the calf.
And can cause compartment syndrome?
No, I wouldn't say no, and I wouldn't say yes, because technically, yes, it could. If there's enough bleeding and that bleeding is not resolved, technically it could, yes. If you think about it with an acupuncture needle, unless you are probing, unless you are really damaging that artery significantly, and remember, the patient must be lying there and accepting it. And if you stick a needle into the artery many times, it's going to be tender. And when you cause the bleeding, the patient's going to feel something different happening. So I don't know whether you're actually able to cause enough bleeding with an acupuncture needle to cause a compartment syndrome. Okay, but I wouldn't put my professional status on the line and say, no, it's not going to happen. The potential is there for it to happen, but I do not know of any published case studies whereby dry needling has caused a compartment syndrome. And whilst you mention the word compartment syndrome, I'm not going to go into it in much detail. What I'm going to say is that needling, for true compartment syndromes, needling is not indicated because a compartment syndrome is a lack of blood flow into the compartment as a result of the fascia being too tight. There your patient requires a fasciotomy, but after compartment syndrome has been fixed, the muscles may have chronic stiffness that could be needled, which would make the stiffness that is often associated with people who suffer from chronic compartment syndrome, that could be needled. Okay, should we move on?
Thank you. Thank you.
Pleasure, no problem. So clinically, there are a couple of conditions that you are not going to needle if your patient presents with these conditions. For example, not going to needle in the area of active malignancy. If your patient has an active cancerous lesion, for example, an osteosarcoma of the femur, they have pain in their quads or their hamstrings, and they come to you, they don't tell you about their malignancy, well, then that's unlucky. But if you ask them, do you have any medical issues? Are you taking chronic medication? Do you have any issues going on? They say, yes, I have a tumor in my femur that I'm putting treatment for. My quadriceps is very sore. You're not going to needle the quadriceps because of the effect that needling has on, number one, pressure and circulation. Number two, okay, so no presence in needling in the presence of active malignancy. If your patient is in remission, they've been in remission for years, you can needle your patient. If your patient has a cancer of the femur and they want needling for the trapezius, you can needle the trapezius very gently because the needling in the trapezius area is not going to affect the blood flow lower down around the femur. All right. Number two, we do not needle into open wounds. For example, bed sores or diabetic ulcers. We do not needle open wounds. So some of these contraindications are quite obvious. Number three, if you know that your patient has got severe arteriosclerosis, in other words, a buildup of fatty tissue inside the arteries, and it is occluding the vessels, don't needle your patient because needling can cause blood flow changes or blood pressure changes. Same again, if your patients have a weakness in the artery, an aneurysm, and they know about the aneurysm, well, then you've got to be careful of needling that type of patient. Also, your patients with specific neuropathies, so in other words, where they cannot feel, they have no sensation, either in their ankle or their calf or their lower leg, well, you need them to be able to feel the needling and to give you feedback. So no needling in the areas of where there may be a sensory neuropathy. Same respect for your patients with advanced osteoporosis. No needling, especially no needling down to the bone. And specifically with hip pain or with shoulder pain, because of the neck of the femur or because of the neck of the humerus, because we do sometimes needle to the bones. Very often I will use the bones as protection. So the needle does not go through to a deeper structure that you don't want to. Specifically, if you know that your patient is osteoporotic, do not damage the bones with the needle. Okay. Now, there are some other contraindications and precautions that you must take with needling. For example, you cannot needle the patient who is needle phobic. In other words, they are fearful of being needled, or the unwilling patient. The unwilling patient cannot be needled, so you cannot strap them to the bed and force them to be needled, because all forms of treatment have to be accepted. You have to have informed consent from your patient. If you want to do a manipulation on your patient, you have to describe your diagnosis, to describe your treatment, and the patient has to accept the treatment. Same for dry needling. And so now we highly recommend that when you needle your patients, you get written, signed, informed consent that they accept that you are going to needle them and that they are willing to be needled. You cannot needle the patient that cannot give you consent. For example, a patient that is too young, they might need guardian or parental consent, or the patient that is unconscious, for example, cannot needle them. Do not needle the lymphodematous limb because you are likely to aggravate the lymphedema. Do not needle a patient that has a recent joint replacement, for example, the knee, okay, or the hip. Do not needle recently. So in other words, if the stitches aren't out, if the wounds haven't healed, not needle near to the operation site. Your patients with diabetes, especially with peripheral needling, often your diabetic patients have very sensitive skin. You don't want to needle them aggressively or continuously and upset the sensitive skin. Pregnancy. You must know the status of the pregnant ladies. Okay? The first and the third trimester, your pregnant ladies are most at risk of losing their fetus. Now, there is nothing in the literature to indicate that dry needling or acupuncture will cause any pregnancy issues. And we know that lots of pregnant ladies go for acupuncture for pain. So you may choose, if you know that your patient is pregnant, you may choose to do another therapy and not needling, because if something were to happen and she were to blame it on the needling, then you would be caught up in that game. And so to remove yourself from that, you may choose not to needle pregnant ladies. And then lastly, epilepsy. You can needle the epileptic patient provided they are on controlled medication. All right, if they're not on controlled medication and you know they're an epileptic, then do not needle them because it may cause an epileptic. Where do we not needle? Quite obviously, we don't put needles into any orifices. Okay, we don't needle the genitalia. Don't needle the belly button or the umbilicus. If your patient has breast implants, we don't needle into the breast implants. And similarly, we don't needle into the female breast tissue or the areola or the nipple. We don't needle under the nails. We don't needle into inflamed lymph nodes. And if your patients have any devices, we don't needle into or near to the device. So many of these are quite obvious, and that you're not going to needle into most or all of those areas. Okay, so mainly we are needling muscles. If you are an advanced dry needling therapist, you will needle ligaments, ligamentous pain, tendon injuries. We don't needle into the non-musculoskeletal tissues. And similarly, now that we are needling our patient, what we have to be careful of that could happen with needling. Some of these do happen, and some of these are very, very rare. Persistent pain. But by this, I mean you stick your needle into your patient, it reproduces their pain, it makes their pain a little bit worse, and that pain doesn't get better. Pain doesn't go away. Take the needle out, change the position by 2 or 3 millimeters or half an inch, and put the needle in again. Hemorrhaging or a hematoma or a contusion. You won't get hemorrhaging in the muscle unless you hit an artery. Okay, we'll get micro bleeding and micro trauma within the muscle that may cause mild bruising, mild treatment soreness. Hemorrhaging and a hematoma is often caused by the needle going into a small arteriole and the patient exercising after that, or going into a major artery. The patient may faint while being needled or after being needled. So when you needle your patient, when they're ready to get up off the bed and the treatment is finished, they must sit on the bed for 30 seconds and make sure that their blood pressure is restored to normality. Okay? Also, when you needle your patient, you must make sure that you position them in a safe position so that they don't faint during the needling. And a safe position would be in lying, a supported position. Patients could also get a vasovagal attack and convulsions during needling. Very, very, very rare. Sometimes the needle gets stuck. The needle will never, ever get stuck such that it won't come out. All right? There's no such thing as a stuck needle. If the needle feels stuck, all you do is you stimulate the needle, you twist the needle, you flick the needle, and you take the needle out. What I'm finding more and more commonly now is the bent needle, and that is a picture of a bent needle. Okay? Now, I have not bent that needle. The muscle has bent that needle. All right? So here's a needle. I'm taking a needle. If I bend my needle like that, there is a bent needle. Okay, you can all see that bent needle. All right, there it is over there. Now that bent needle and the bent needle in the picture, all right, I bent this needle with my hands. I went like this and I bent it like that. All right, it's bent. That needle in the picture was bent by a muscle in the body. Now, how does that happen? And bent needles are fairly common. What happens is if you put the needle into two different muscles or into two different portions of the same muscle that react differently. For example, multifidus. That needle came out of a multifidus muscle. So we know that the multifidus muscle runs from the transverse process of the vertebra below to the spinous process of the vertebra above. So it runs at an angle. So if you put your needle in towards the vertebra, you can go through 2 or 3 different multifidi because they're going at an oblique angle from the vertebra below to the vertebra above. And multifidi can react differently, and that's what's happened in this instance here. You had the one multifidus being in a relaxed position, and the other multifidus went into spasm, and the needle got caught in between, and what resulted was a needle. Now, the literature does describe broken needles, and I've never ever seen a broken needle. I've never had someone report back to me about a broken needle. I think it's highly, highly rare, but it is reported in the literature. Other adverse reactions and complications can be infection, obviously. So we make sure we use sterile needles, we clean the areas, we use gloves, you have a sterile clinic, you keep your clinic nice and clean, you wash your hands on a regular basis. I'll tell you what needling will often cause is fatigue and drowsiness. And some of you who do needle may have experience with some of your patients where after a needling session, they go home and they feel really, really tired. They feel drained. And that is because of the needling and because of the neurological effects that needling can have centrally, like we described earlier in the presentation. Now, damage. Needles can cause damage. The hypodermic needle will cause more damage than the acupuncture needle. Needles can still cause damage. So, for example, if you stick a needle into the lungs, you're going to cause a pneumothorax. Okay? Your patient's going to present with chest pain, different to their muscle pain. they'll have a dry cough for a couple of days, or the next day after their needling, might be short of breath, and there may be signs of a pneumothorax on X-ray. Okay, so avoid putting the needle into the lungs at all costs. Avoid sticking the needle into the abdominal organs, so into the intestines. If you're needling the abdominal muscles, we needle at an angle, or we needle with a short needle. Avoid sticking the needle into the kidney. What muscle might you be needling if the needle goes into the kidney? Well, most commonly, gradus lumborum. And the kidney goes from about T11 down to L2, L3. So half of the kidney is covered by the lower floating ribs. The other half of the kidney is exposed lower down in the lumbar spine. So if you don't know where the kidney lies, and you take a 75mm needle, you put it straight down just below the 12th rib, you will hit the kidney. It's not going to be life-threatening. It's going to cause flank pain. It's going to probably cause a little bit of blood in the urine. The kidney is going to heal. However, it's not best practice to put the needle into the kidney, or into the abdominal organs, or into the lungs. You have to be taught, and you have to learn, and you have to remember with your superficial anatomy which structures to avoid, so you don't cause unnecessary damage to your patients. The last thing that can happen is a needle stick injury. And a needle stick injury is when the needle, a dirty needle that's either been on the floor or that's been in another person, enters into a third party. So either the therapist, it's a needle stick injury because they've been needling the patient, they take the needle out and they try and put the needle back into the tube, and they put the needle into their finger. Now, that is a needle stick injury for me. I have to wash that finger, and I have to maybe go on preventive medication to prevent getting an infection. For example, common things that you may pick up from a needle stick injury are HIV, or the other infection. I just have a brain spasm at the moment. It'll come to me a little bit later. We'll talk about needle stick injuries at the end of the presentation. Okay. Time is 6 o'clock. Should we take a 5-minute break? If you want to get a glass of water, a coffee, if you want to ask any questions up until now, because the next part that we're going to talk about is actually the needles themselves. Does anyone have any questions?
Yeah, Craig, regarding the last point you mentioned, a stick injury, would you take the needle out and back to the tube to insert into the same muscle, or you just insert one and you just discard the needle?
The needles are reusable. They're definitely reusable in the same appointment session with the patient. So I will sometimes use one needle, and I'll take it out and I'll put it back into the patient maybe 3, 4, 5 times. And what I do is I re-guide the needle. So for example, I'll just demonstrate to you here. Here is my needle, right? Here is the guide tube, and in the guide tube is my needle there. There's the needle. If I take that needle out the guide tube like that, I put the needle into the patient, I fish around, now I take the needle back out, I turn it around, I put it into the guide tube like this. There it is like that. Oops, fell out. I put it into the guide tube like that. Now I can reuse that needle, provided it hasn't fallen on my desk, obviously. And I can reuse the needle within that same treatment session. Sometimes I will fish around, take it out, put it back in the guide tube, fish around again, throw it away, get a new one. Sometimes I will leave the needles in for maybe 3, 4, 5 minutes, take them out, throw them away, or re-guide them. Don't have to throw the needle away once it's come out the body, because that needle is going back into the same person. It's not picking up any germs. And in my 30 years or almost 30 years of needling, I have never, ever had an experience where a patient has come back with a skin reaction, skin infection, or any other type of insidious reaction from reusing a sterile needle. Okay, so long as you're reusing them within the 10 to 15 minutes of the needling session for that patient, you're completely fine. Any more questions, guys?
Yes, please. Can I ask one, please?
Go right ahead.
You mentioned the dry needling according to the muscle, but about the mechanism regarding the muscular problems. But how
Ah,
about the physiological? I mean, how does it work with the tendons and ligaments?
okay,
And
right. Yes, there's a difference there. Yeah, that's a good question. Very good question. So for muscles, we're mainly needling trigger points and we're needling the contractile elements of the muscle. And we're looking to deactivate the contractility of that muscle, the spasm of the muscle. Okay. Sometimes we don't get twitches because we're needing scar tissue or adhesions, fascial layering tightness. When you needle a tendon, when you needle a ligament, it's completely different. It's different tissue. There's no contractility in a tendon or a ligament tissue. The tendon is merely the extension of the muscle. So we needle a lot more gently. We do not probe into the tendon like we probe in the muscle. You really need to see how the tendon needling is demonstrated on a face-to-face course to know that, firstly, you can do a lot more damage with the tendon, needling the tendon, than you can with the muscle. Therefore, your style of needling for tendons is very different. It's very slow. Only put the needle into the painful, degenerative, nodular area of the tendon where the tendon tissue is necrotic, it's dead, it's lacking in blood supply, it's got scar tissue, mainly it's made up of scar tissue, and you're trying to get a little bit of proliferation or healing of that tendon tissue, the degenerative tendon tissue, by improved blood flow. The same for the ligament. Ligament injuries, which are chronic, are as a result of the ligament tissue not healing in the normal striated fashion, the presence of scar tissue, which is not allowing that ligament to stretch and to stabilize. And when that ligament wants to stretch, the scar tissue is holding it, preventing it from stretching, and it's painful. So you come along with your needle into the painful sites of the ligament, and you cause a traumatic reaction, which would be similar to cross frictions or similar to a deep tissue massage for that ligament. You are fishing around in the ligament to micro traumatize the scar tissue to get the scar tissue to heal. Okay, so the reason for needling tendons and ligaments is different for muscles, and the technique is different as well.
thank you, sir.
Pleasure. Any more questions?
Yes, doctor. Is there an optimum time for needling?
Is there an optimal time? Yes, yeah. In other words, I'm understanding your question. How long do we needle for? How long do we leave the needle in? We're going to come to that. We're going to come to that further down in the presentation. I'll discuss that.
Doctor,
Okay, so let's move along. The needles, acupuncture needles, are stainless steel mainly, single use, as in single use in a treatment session. Not put those used needles into a container and bring them out again next week for the same patient. Throw them away, and throw them away in a sharp spin. Okay, a sharp spin that would be given to a medical incineration company and that they will be disposed of correctly. Needle comes with a guide tube. There it is over there, and the guide tube helps you put the needle in easily. Needles are disposable, so we throw them away. We don't reuse them because of the spread of AIDS and hepatitis with your needle stick injuries. And the needles are normally a little bit longer than the depth of the muscle that we're going to needle. So that's, if the muscle depth is that deep there, and that's a 50 mil needle. If the muscle depth is 40 mils, we'll use a slightly longer needle so that we don't necessarily go all the way to the hilt or to the handle of the needle. Therefore, needle size that we choose is dependent on our anatomy. We're not going to take a 75 mil needle for the face because the facial muscles are only 25 to 30 mils thick. We're going to use a 15 or a 30 mil needle. All right. So there's your guide tube. There's your different size of needles. There's the handle. There's the tip. That's the shaft. The size of the needle, so for example, if your needle is 125 mils long, or if it's 15 mils long, that is the length of the shaft of the needle, the stainless steel component. Some needles come with a stainless steel shaft and a copper handle. Most of them will come with a stainless steel shaft and a stainless steel handle as well. The sizes of the needles are important, and you'll notice that the longer the needle, the thicker the shaft of the needle, so that it's not too bendy and wobbly. The shorter the needle, the thinner the shaft. So your 15 mil needle will have a diameter of about 0.20 or 0.22 mils thickness, whereas your longer needles, your 75s, your 60s, their diameter will be 0.35 or 0.40 millimeters thick. This is the difference between acupuncture needle and the hypodermic needle. That needle is sharp, cuts the skin. That needle is round tipped. It doesn't cut the skin. This needle here is stiff, flexible, and hollow. This needle is wobbly, bendy, and it's solid. Okay, so if you take a look at the end of the acupuncture needle, you'll see that it's actually got a pointy, rounded, so it goes in and it pushes the skin and the muscles apart. It doesn't slice muscles. However, this needle can still cause damage if it goes into a nerve or an artery or into the lungs. So we are very cautious as to how we needle, where we needle, size of the needle, and the angle and the direction of the needle. All right, so what is our protocol now? How do we position our patients? How many needles do we use? How long do we needle? How do we combine our needles with our other forms of treatment? What is the protocol? But our patient is always recumbent. What does recumbent mean? Recumbent means that they're in a comfortable, safe position. A recumbent position would be a patient lying on the bed, supported such that, or in a forward-seated chair, such that they are safe if they were to pass out or faint. We only use sterile needles, brand new sterile needles. They come in a pack, a vacuum pack. They haven't been opened. Do not use an old needle. After your needling, you can do other forms of therapy. You can do your electrotherapy. You can do your stabilization exercises. You can do your gentle stretches. You can do your movement and posture re-education. What you shouldn't do, you shouldn't take that patient through severe or hard exercises. Don't take the patient into the gym and get them to do 100 kilograms of squatting or 100 kilograms of bench press. All right? Why? Because that patient's muscles has been micro-traumatized. You've caused slight damage to the muscles, and if you go and overexert those muscles in the gym, you do plyometric exercises on a calf muscle that you've just needled, there's a good chance that you are going to tear that muscle, right? The gentle treatment after needling is quite acceptable, provided you don't aggravate the effects of the needling, and provided you don't cause excessive trauma to the muscle that has been needled. You can definitely apply hot packs or ice after your needling. And the theory is that if you have a patient that is very acute, has got a severe trigger point, they've woken up with a stiff neck and they've come to see you, needle them gently. You want to get that spasm to relax. You want to improve the blood flow to the area because the muscles are tight. You want to relax the muscles and fuse that tight muscle with blood. So you're going to give them a hot pack after your treatment, promote superficial blood flow. Whereas if you've got a patient that you're needling, you've got a chronic condition, is maybe 6 weeks after a muscle strain, needling the stiff scar area of the muscle, and you're needling that muscle aggressively. Needling like this. You're probing into the muscle for maybe 5-10 minutes. Leave the needle in. You might put 2, 3, 4 needles in. You might even do a bit of passive movements with the needles in the muscle to stretch that scar. That muscle is going to feel bruised and sore. There's going to be soreness after that needling session. That is where you tell your patient to go home and put ice on their muscle. Or after the treatment, you give them an ice pack to minimize the soreness of the treatment. Okay, you don't want to minimize the bleeding. It's going to be micro-traumatized in the muscle, but you want to minimize the treatment soreness that the patient is going to feel. Okay.
Can I ask you a question, please?
Yes, please go ahead.
It has to be a strained muscles, or even if some sport or bodybuilders have a very tight muscles, like looked long with anterior pubic tilt, hamstring looked long.
No, you don't have to only needle a strained muscle. You can needle a tight muscle, a stiff muscle. You will be needling acute muscle spasm. The philosophy that I'm just saying is that in the acute patient, you know, the patient that presents with an injury, you're going to do a hot pack after your needling if you're going to do heat or ice. Whereas the patient that's got a chronic condition that you're going to needle aggressively, because this acute patient, you're not going to needle aggressively. They won't allow you to. You're going to put a needle in, you're going to leave it there for 2 or 3 minutes, take it out, put it back in, and leave it there because the spasm won't allow you to probe the muscle. Now you take a completely different type of patient. You've got chronic muscle pain, chronic muscle tears, chronic spasm, chronic tightness, chronic stiffness. You can still exercise. It's been around for a long time. You want to traumatize that area because you want to promote blood flow, get it to heal. So you aggressively needle that stiffness in the muscle. And afterwards, you tell the patient to ice if the needling causes bruising. So to minimize the treatment soreness, you would advise them to do cryotherapy. Does that answer your question?
Yes, thank you so much.
Pleasure. Okay, so continuing with the protocol. Now we've got the patient in our hands. We've plated them. We've got the needle ready to stick the needle in. How do we do that? We localize the area. We localize the trigger point with the palpation. Okay, we find the exact point of the patient's pain, and we stick the needle in with a strong tap. Now I'm going to demonstrate to you guys on myself how we do that. So I'm going to just roll up my shirt here. I'm going to take a 30 ml needle. I'm going to clean my arm. Now I've got a sterile needle, right? There it is over there. It's in the tube. There's the handle sticking out. I hold the handle against the tube like that. I put my forearm like that. And I rest. I find with my palpation where is the patient's tennis elbow pain in the muscle. There's the and there. I put the guide tube on top.
See you.
You can see me, right?
We cannot see. We only see your presentation.
Oh, sorry. Hold on. Let me change this. Oh, I'm very, very sorry. Thank you for saying it. Let me just change the.
No, I can see you. Just press the.
Okay. Is that better? You can see me. If you change your view, you'll have me in full screen.
Yeah. Now we can see you.
Okay. Right. So back to there. Okay. I palpate. Where's my pain? Now I stick the needle, the guide tube. You can see the needle is up the guide tube, right? I stick the guide tube on the skin and I now tap that needle. Can you see that 5 millimeters of that needle is sticking out the guide tube, right?
Yeah, right.
Now I tap it in. Now the needle is in. There the needle is in my muscle. Okay. Now I can push the needle in and out like this into the muscle and find the painful area. And I'm going to needle for approximately 1 to 2 to 3 minutes, depending on the patient. Depending on whether the patient is agreeable with needling. Some patients are very averse to needling. Those patients, you make sure they don't watch you needle them. Make sure that you don't needle them aggressively. You might put the needle in and just leave it there. That's what we call passive needling. You might take the needle out, put it in again, and do 1 or 2 fishes and get a couple of twitches and leave it there, because that patient is anxious. That patient is scared of the needle, so you don't want to cause too much sensitization while you're needling the patient. Whereas other patients, like Naima said, they come back for needling all the time. You stick the needle into them like that, and you can probe in and out. I'm not going very deeply because my extensors are very flat and shallow muscles. I can even take another needle and I can put it in next to, so we can needle with 2 or 3 needles in the area. There's another one going in there. Now I've got 2 needles in my forearm, one like that.
Doctor, the camera is on the other side.
Yeah. You guys can see clearly, right?
Yeah.
I can see myself. Yeah, sorry. I need to make sure that my forearm stays in the middle. So now I've got 2 needles in the patient's area. You can use up to 4 or 5 needles, depending on the size of the muscle, depending on the size of the trigger point. Right? If the trigger point is that big in the muscle, well then 3 or 4 needles can fit in that space together, separated by half an inch or an inch, and you can needle and then needle one in, leave the one needle in, the needle in, another second needle, rub around, put a third needle in. Now with those 3 needles in there, you can change their positions. Take one out, change the position, put it in. Take the other one out, change it, and you move around that trigger point, that band in the muscle, slowly deactivating the whole of that band. And that treatment session may take anywhere from 15 to 20 minutes. So there's no defined time that the needle stays in the body. Okay? The things that you have to consider are, does the patient like needling? You can needle them for longer. If the patient is anxious, you're not going to needle them for a long time. How acute or how chronic is the patient's condition? If they are acute and painful and in spasm, you're not going to needle them for a long time. You're not going to be aggressive with your needling. You're only going to use one needle, and you'll change the position of that one needle maybe 3 or 4 times. Whereas if you have a patient with a chronic condition, have recurring hamstring strain, they've never had that hamstring tear fully seen to, you now want to needle into that hamstring, recreate their pain, and you're going to use 3 or 4 needles, and the whole session is going to take 20 to 25 minutes, because you're continually finding areas in the hamstring that is painful, and you're using 3 needles all the time. That's quite permissible. What you must advise your patient after that is that they're going to be sore. All right, going to be bruised because you've needled them for a long time, needling with 3 or 4 needles. Okay, I'm going to bring up the presentation again.
Doctor, can I ask you a question, please?
Yes, please go ahead.
Regarding the dry needling fishing, is there a specific angle you have to do it, or you should just go 90 degrees?
Are we coming to that right here on this slide here?
All right, thank you.
So I'm going to answer that question on the last point. So we give a nice, quick, strong tap to get the needle in. If you cause a little bit of bleeding, and the bleeding I'm referring to is skin bleeding, that is a small venule under the skin that has been penetrated by the needle. It's completely harmless. You take the needle out, you get a little bit of blood on the skin, take a cotton wool swab, you apply pressure for 10 seconds, 15 seconds, that bleeding stops automatically. Okay, that's absolutely no problem. We can probe, flick, twist the needle, we can flick the needle if we want to stimulate the needle, if we want to stimulate the muscle a little bit. If we flick the needle, we cause a bit of vibrations down the needle into the muscle. That little vibration spreads out the muscle. The patient can actually feel that vibration. If the needle is stuck, we can twist the needle left and right, try and pull it up and to take the needle out. Okay, just an example, if you have a stuck needle, your needle is not coming out because of the spasm, because now the muscle is gripping around the needle, put another needle in alongside that needle to try and relax the muscle so that that stuck needle can come out of it more easily. Remember, there's no such thing as a stuck needle, all right? That needle will come out. Then, the depth and the angle are very important because sometimes you're needling a muscle, and below that muscle is a structure that you don't want to hit. Let me also say that we don't needle at angles or directions in the direction of the fibers. We do not needle in the direction of the fibers. Okay? We needle in the best manner possible to hit the painful spot, because our needling is directly related, our accuracy of our needling and our effectiveness of our needling is directly related to hitting the spot, hitting the trigger point, reproducing the patient's pain if we can, being in the right area. And often that requires us to change our angle very subtly. So you'll see that when I fish, when I put the needle in, I'll sometimes change the angle just so that I am trying to find the exact spot where I want my needle to be. So if the muscle is running in that direction, there's no need to needle along the direction of the muscle fibers. We do not needle in accordance with the fiber length. We needle in accordance with where the pain is, also to avoid putting the needle into the kidney or into the lung. So let me give you an example of change of the angle. If we're needling rhomboids, rhomboids lies over the ribs. If we needle in the direction of the rhomboids fibers towards the scapula at 45 degrees, that means that the needle will not go vertical down into the chest and will avoid pneumothorax. Similarly, the rhomboid fibers are traveling approximately parallel to the ribs. So if we then needle across the rhomboid fibers from inferior to superior or from cephalad to caudad, the needle at 45 degrees is highly unlikely to go into the chest because it's going to hit either one rib or the rib below. So that is a reason why we might needle rhomboid muscle or any other muscle at an angle so that we avoid the needle going vertical down into the structure below. Another reason why we might needle at an angle is, for example, sternocleidomastoid, right? That muscle over there. There's my sternocleidomastoid. That is a very thin muscle, very thin and very long. We want to needle down the length of the muscle. Guys, can you please mute your microphone? We want to keep the needle in the muscle. Okay, so we needle down the length of the muscle, because if you needle through sternocleidomastoid in a medial direction, what lies there that I can feel? The pulse of the carotid artery. And if you take a 30 or a 40 and you needle into sternocleidoid in a medial direction, you've got a good chance of hitting the carotid artery. If you've taken an even longer needle, you've got a good chance of that needle going into the trachea or the esophagus. It would be very difficult because that trachea is quite a firm structure. So the depth of our needling and the angle of our needling is very specific in some muscles, and in other muscles it's actually non-specific because those are very safe muscles to needle. Right, how many needles do we use? We use 1, 2, or 3 needles depending on the patient, depending on the size of the injury, depending on the acuteness of the injury, depending on how much of that band we want to deactivate.
Excuse me.
Yes.
Do you use the? I want to ask this question: how many needles do you use? It's depend on the presence of the trigger point, or you will apply 2 or 3 or more needles?
Yeah.
So
Yeah,
what?
the number of needles is dependent on the size of the muscle and the size of the trigger point in the muscle. So if I'm needling sternocleidomastoid, my trigger point, I can palpate, it's over there. It's pointless needling that area with 3 needles because there's not enough space to allow 3 needles into that sternocleidomastoid muscle. So I will use only 1 needle. I will put it in, I will fish around quite gently at an angle, and I will leave the needle there. And I will come back 2 to 3 minutes later, take it out, put it in a similar place, fish around, and leave it in there. And I might needle for 15 to 20 minutes because it's a small muscle. So I'm only using 1 needle. If I'm needling the hamstrings and the size of the trigger point is as big as this little dongle here, I can use 3 or 4 needles because it's a big hamstring muscle, because the multi-needling. All right, so we use multiple needles, bigger muscles with big trigger points. How long do we leave the needles in for? Your treatment session with your patient is anywhere from 25 to 35, 40 minutes. If you're going to be needling them only, you probably needle them for a maximum of 25, maybe 30 minutes and no more, because that would be a lot of needling. All right. And if they can't tolerate that amount of time because of their anxiety towards needling, well, then you're only going to needle them for maybe 10, 12, 15 minutes. Generally, we leave the needles in for a maximum of 5 minutes, 2 to 3 to 5 minutes, and then we change the position of the needle, the angle of the needle. We might throw the needle away and get a new needle. We might decide, well, I want to try a longer needle now, because I've been needling my hamstring muscle with a 40 mil needle and only beginning in that far. And now I want to go all the way down, full volume of the hamstring muscle, because the band might be sitting at the bottom of the muscle, closer to the femur, and I want to get my needle to that band. So you may change your needle because you want a longer needle or a shorter needle. You may decide to change your angle because you're not getting the response back from the number one, the patient, their feedback. Number two, the needle in the muscle. Because when you stick the needle in the muscle, you can feel when you go into the trigger point. Number one, you feel the twitch response, the muscle automatically jerks like that. And number two, you can feel a resistance, increased resistance on the needle when you're going into tension, spasm, trigger point, scar tissue, adhesions. Resistance on the needle becomes greater, and you can subtly feel that you're in the right area. So you may choose to change the angle of your needle if you're not feeling anything in that muscle. And after needling for a number of months or years, you will get to feel the needle in the muscle and know when you're in the right spot, and also know when you're in the wrong spot, because the needle is going in nice and smooth. You're not picking up any tension changes. That's when you might change the angle of the needle or change the size of the needle, or you might even change your positioning. So you might decide to start 2 or 3 inches this side now and change your angle to go that way. Whereas before you were going vertical, now you're going to change it and go at this angle to see if you get a better response. Because our musculature is 3-dimensional, and the architecture of the muscles is such that if you stick a needle in straight down, there's no guarantee that you're going to get into the right place first time. Because number one, your angle might be subtly off, and now you're going in that direction. Or number two, you might not get down deep enough because you've chosen a too short a needle. But when do you probe or when do you fish? This is called fishing. When your needle goes in and out. When do you probe and when don't you? When do you leave the needle static? That depends on the severity of the condition. It depends on the acuteness or the chronicity of the patient's condition. If the patient is very acute, well, then you needle passively and you put the needle in, you leave it alone. When the condition is chronic, that's when you fish around a lot and you go in and out to create microtrauma. You can stimulate the needle anytime. You don't have to stimulate the needle, and you can leave the needle on its own. We've spoken about other therapies before or after. Just to give you my own experience, I always ended up needling my patients at the end. If I was going to do any other treatments like joint mobilization, myofascial release, then I would finish with needling for the patient. And we've also spoken about isoheat and when to do that, so I won't go into that again. I want to now just talk about what happens if needling fails. Sometimes we don't fix our patients. Sometimes our patients don't get better. Now, I am a full-on believer in dry needling. It really, really works. But sometimes patients don't respond in the manner that we think they're going to respond. What is the reason for that? Either you're needling into the latent trigger point and not the active trigger point. So, rule of thumb, you must needle into the patient's pain. Their pain coming from the muscle will come from the primary active trigger point. Number two, you know your needle is going into the band because you can feel that change in resistance. But you're not getting that twitch. Therefore, you're only in the band. You're not actually in the fibers that are trigger point fibers. You're missing the trigger point, and you need to fish around in that band more to get the twitches. Thirdly,
excuse me.
Yes.
Excuse me. LTR is always the evidence of the trigger point.
Yes. If you get a local twitch response, that is an evidence of a trigger point, correct? And that is what you are aiming for. The more twitches, the better response the patient will have in terms of pain reduction. Okay. Also, your patient might not get better if you cause too much bleeding. All right. So you must know that if you needle very aggressively, encourage the patient to put ice on afterwards to limit the amount of bruising. Also, remember that trigger points can cause weakness. They can cause dysfunction. They can cause changes in muscle function. So if you release the trigger point and the pain with the trigger point, you must get your patients to rehabilitate that muscle. Otherwise, the trigger point and the pain will come back. So they've got to be doing their home exercises. They've got to be doing their strengthening exercises. They've got to be doing their functional exercises as well to keep the muscle working properly and strong. Needle safety. So we only use disposable needles. We only use sterile techniques, and we get rid of our needles into our sharps bin. Okay? Don't leave the needles lying around on your trolleys, on the bed. Go into the sharps bin. Needle stick injuries. We spoke about this earlier. The needle stick injury is when a dirty needle goes into another person. Right, so that can happen. The patient is not going to get a needle stick injury with their own needle. Therapist or the secretary, if they get punctured by the patient's needle, that is a needle stick injury for them. What do? You clean the area with alcohol or water where the needle went in. Or if it's saliva or blood, a mucous membrane, you rinse the mucous membrane, you rinse the mouth or you rinse the eye from that fluid. Explain to the patient, if necessary, that they might need to go to the doctor, they might need to be put on preventative medication. So, post-exposure prophylaxis is necessary for blood-contaminated needles, a hypodermic needle or acupuncture needle, injury with a blood-contaminated sharp instrument, for example, a scalpel, exposure to mucous membranes, so someone else's fluid into your mucous membranes, or blood contamination on broken skin, prolonged exposure on normal skin. You must encourage your patient to go for post-exposure prophylaxis, preventative treatment within hours of the incident occurring. Okay, and then professional indemnity or informed consent. We must get permission from our patients, and it's highly advised to get written permission from the patients before you can needle. You must explain to them what needling is. You must explain your diagnosis to them, that their pain is coming from a trigger point, and that it's going to be effectively treated by sticking a needle into the trigger point. You want to reduce their pain. You also want to get the muscle to twitch. You can describe that to your patient as a crampy sensation in their muscle. So when you put the needle into the trigger point, you reproduce the patient's pain, they're going to feel that pain as a cramp in their muscle. And they must be taught that that is the correct response that you're trying to elicit so that you can continue to deactivate the muscle and you can get them to put up with the discomfort of that painful cramping of the twitch response. Okay.
Excuse me, doctor. Excuse me. Yeah. Can you provide the one sample of informed consent after the session?
Yes, I've got a document that I think I will send everything to Zahir, and he has your email addresses and he can forward that to you guys, and you can use that in your practice, or you can make up your own informed consent document.
Mr. Craig.
Yes.
I want you to take a cup of water, please. Take a cup of water, please. Take rest.
A cup of water?
Yeah, take rest. Take rest for 5 minutes, please.
Okay, can we have a 2-minute break? And then I'm going to show some videos. Because we've done with the theoretical of what I wanted to show you. And then I'm going to show you some dry needling videos that I've taken on previous courses for some of the muscles. We'll do maybe 3 or 4 muscles. Give you an example. Okay. Is that all right? Okay, let's take a 2-minute break and I'll be back. All right.
Sure, doctor.